Hello, my name is Adam Schwartz. I'm an emergency physician at San Diego Kaiser Permanente Department of Emergency Medicine. I'm Chief of Service and Academic Chairman. This is a talk on electronic chart assignments' impact on emergency department operational metrics. Some background here to start. Kaiser Permanente San Diego is an emergency department that includes two large urban teaching EDs. It's staffed by one physician group. This intervention was done at one site only. Both sites include an emergency medicine residency and point-of-care ultrasound fellowship. Approximately 12% of patients are seen by trainees. It should be noted that this is a partnership group without a productivity incentive. Prior to the intervention, there was a 61% difference in patients seen per hour between most and least productive deciles. Patient distribution by physician self-assignment was undertaken with no regard to location or ancillary staff. For the study, we wanted to examine whether an electronic patient assignment system improved operational metrics. Here are the methods. This was a retrospective observational study. It looked at routine ED operational metrics. Before the intervention was January to June of 2018. Post-intervention time was July to December of 2018. The intervention obviously was an electronic chart assignment system. 54,613 patients were studied. It should be noted that this was for discharges only. There was minimal seasonal variation of volume. This system ran continuously during the study intervention time. It utilizes a sophisticated algorithm to assign patients to a physician based on acuity, that particular physician's current historic workload, and multiple other factors in an attempt to bring equity to those physicians working at one time based upon patients per hour and acuity. Multiple metrics were studied, including arrival to room, arrival to dock, length of stay for specifically ESI 4 and 5 patients, and the percentage of those patients who left without being seen. Here are the results. Average arrival to room decreased by 13.5%. This had a range of 49.4 to 42.75 minutes. It should be noted, however, though, that the p-value is 0.13. Average arrival to dock decreased by 11.4%. This was also not significant, but 67.07 minutes to 59.4 minutes. Average length of stay decreased by 10.9%. This is significant. It decreased from an average of 405 minutes to 361 minutes. Average length of stay for ESI 4 and 5 patients also decreased significantly, almost to 12%. This was also significant data, 148 minutes to 131 minutes. Monthly average patients who left without being seen decreased 22%. It should be noted also that this data was not significant with a p-value of 0.36. In conclusion, electronic patient assignment system improved operational metrics in this busy not-for-profit hospital's emergency department. Work equity was obtained in the physician group, and overall satisfaction was significantly improved. It should be noted that a few things may bias this study. There was significant adjustment period for the physicians and especially the staff getting used to assigning the charts. And there are multiple confounders. Obviously in July we had residency classes turnover, so the post-implementation group was actually done with a more junior house staff. And in October, we had to make subtle changes to the schedule because of changes in demand, and we wanted to match clinical demand more efficiently. That's it. Thanks for listening.